as a person. I'm really fortunate and feel very honored to introduce Dr. Anirban Chatterjee, the CEO and co-founder of Haystack Analytics. In the time that I have interacted with him, I really do not know a better person who can bring this to us in a very lucid fashion. Anirban has a 15 plus years in data science and research, specializing in infectious diseases and genomics. He has worked very closely with the ground realities. He was at Oxford University as a key member of the team that pioneered the development and deployment of the world's first clinical genomic solution for an infectious disease at a population level. He has been an innovator in tuberculosis diagnosis and played a pivotal role in introducing and advancing the use of whole genome sequencing, not only in a developed nation, but has also successfully brought it into a developing into a country where this needed to be more affordable and accessible. He has made, I think, a global impact on antimicrobial resistance by his influence, which extends and is instrumental in incorporating AMR solutions, not only for TB, but now also expanded to other horizons. So over to you, Anirban.
Thank you, Dr. Mahua. Now, first of all, for everyone who have stuck around and joined this new link, we're extremely thankful for your patience. I'm really sorry for the glitches that we have faced this evening. We hope that going forward, we will do better. Further, my apologies for a title of the talk, which seems more like fortune teller than a scientist. I hope that over the next 15-20 minutes, I'll be able to do justice to the time that you are spending with us. It is a fact that genomics is all around us. I just wanted to take some time out to bring some context to what it means. And while none of us require a reminder of what the world has faced in terms of the pandemic in the past 2 years, it is only but natural for me to take this example and bring to fore the core problem. And it like most things in healthcare today, which is extremely advanced, they're having a research publication which is talking about a fever of unknown origin, a pneumonia of unknown origin, a new kind of an outbreak is not uncommon, and so was the case with the novel coronavirus back in 2019, a very nondescript paper coming out of China. And the world had taken notice. But then I think because we had seen so much of this all around the world over the past few decades, we are probably little desensitized to the impact that such a report can have on humanity and global health and economy, as we then went on to find out. And I'm just taking an example of Ebola here. There are several more. Let me just bring to context again that outbreaks and epidemic, these are not new. As a young graduate in genetics, I never thought that I will be able to experience in my lifetime outbreak, epidemic, endemic, pandemic. These are definitions that we use to answer questions in. But when we think of something like Ebola, which has scared the entire world community and has sent shivers down the spine, thinking of how this would progress, it is only important for us to know that it is not about one virus, it is not about one outbreak. This can be us every such time. And this was again seen in the case of the Zika virus outbreaks, which over the past few decades, there have been so many more outbreaks in that case, in several countries, in several continents. I think it is at our own peril and at our own risk if we think that it is not going to be us. It is going to be some other nation. It is going to be some other place. The world is extremely connected, and this extremely in this extremely connected world, these things are more real than we think than we think they are. And just if you start to imagine that, yes, viruses are dangerous, and that viruses hold the spotlight when it comes to infectious diseases, when it comes to such massive outbreaks. Let me again remind you all that it is not just about viruses. If you go around the world is today, many people call it, we're dealing with a silent pandemic, and that's that of antimicrobial resistance. And I'm bringing a few examples to your notice. Let me promise you that this is not even the tip of the iceberg. It is almost like looking at the tip of the iceberg in Antarctica, sitting here in Mumbai. That is the scale of the problem that we're dealing with. Just an example, like back in one of the most developed countries in the world, people are now not even just calling these as bacterial infections. People are calling it a superbug. Bacterial infections, which are very difficult to treat, even with multiple antibiotics that are available today. One such outbreak reported uh, because of transmission through a bronchoscope in California. And if we think that it is probably a first world problem because there have been more antibiotics used there in the past few decades, then again, if I look closer home in Mumbai, a tertiary care center, a not-for-profit care center, which is dealing with some of the most some of the poorest patients in the world, who have the least access to good therapy, such a hospital, a 1,000-bed hospital, is dealing with such antibiotic resistance, is dealing with such infection. And just when we think that, okay, we are talking of superbug infections, we are talking about outbreaks, it is only but natural for us to now get a wider perspective of the health that we are thinking about, of where the world is moving in, with a lot of impact of non-communicable diseases such as diabetes, hypertension, and cancer. Immunocompromised nature of a host means that there are many such infections which are more likely to develop into extremely pathogenic states than earlier before. And it is already evident that post the pandemic, there is a spike of these infections. And let me again bring to fore the point that we are not just talking about infections. That's the point I'm trying to make. We're talking about infections which are difficult to treat. We're talking about infections which has high mortality, high morbidity. And just to drive home the point, it's not just about viruses. It's not just about bacteria. It's about fungi. It's about parasites. Fungal diseases have always been very difficult to cure. With antibiotic resistance, drug resistance in fungi, this is becoming even more difficult across the spectrum of infectious diseases. And in no other disease, it has been more pronounced than in the case of tuberculosis. This is one example. There are countless more, not only in India, in several other countries. This is the plight of a patient who is trying to just find better diagnosis. What is it that is going to treat that patient? The patient is reduced to bones. The patient has spent years to find a hospital which can actually detect what antibiotic is going to work for that for him. And this for a disease for which we have had antibiotics for more than 50 years. There are more than 20 anti-TB drugs which can be used to treat a patient. Despite having these antibiotics for more than 50 years, despite having one of the largest public health programs, the DOTS program, rolled out by the WHO way back, despite India having a national TB elimination program, we're still grappling with one of the oldest known infectious diseases, one of the diseases for which we have so many antibiotics. These are avoidable deaths. What I am saying is, when we talk of infections, it is not just about a pandemic. It is not just about antimicrobial resistance. It is not just about epidemiology. It is not just about global intelligence and research. It is about that individual patient who could have been saved. And this journey of a patient to find the right diagnostics is what is creating one of the biggest problems in healthcare today. We do not have the right tools. We do not have the right data to take the right decision for every patient every time. Ignorance is no longer bliss. When we start thinking of it, what really screams out to me as a researcher over the past 10, 15 years working in the field of genomics, I know that in research, in science, people have used genomics to solve so many of these problems. We moved away from real-time PCRs. We moved away from antimicrobial susceptibility disk way back. And literally, even for each of those examples that I gave you, if I talk about the COVID-19 pandemic, that virus was sequenced. Because that virus was sequenced, we knew what were the RT-PCR targets. Because that virus was sequenced, people were able to find what are the targets for the mRNA vaccines. And because of genomics and several other pieces of science, I'm focusing here on the genomics, the world did something which was unthought of. It was unforeseen. We were able to make diagnostic kits available across the world in less than 3 months, and a vaccine was rolled out in less than 2 years. That is the power of genomics that researchers have been using for more than a decade. And it is not just for creating vaccines. It is not just for creating diagnostic kits. It's actually helping an epidemic, an outbreak stop in its track. In the case of Ebola, the last outbreak of Ebola, people used sequencing on ground to not only find out if it was Ebola or not, to be able to zero in where is the outbreak, what is the P0 in every such outbreak, and to be able to bring public health measures so that that outbreak can be stopped. And it's not just about being able to stop the public health, stop an outbreak. It's about changing the way we look at public health. In the Zika outbreak, when everybody was trying to figure out how did the Zika outbreak reach North America, it was very clear using genome sequencing that there were multiple entries of Zika into North America. Had not it been for genomics, we would have been in a wild goose chase if we would have thought that there was one P0 for the outbreak and the entry into North America. That is how much light genomics is bringing to public health. And truth be told, the way we worked on genomics, it is such a high resolution technology to find mutations, to find transmission, as seen here in this study in the UK. From one patient P1 to P26, just by doing whole genome sequencing, they were able to connect and say, let me just bring up my pointer, if I just may. They were able to find out that from the first patient to the 25th, 26th patients, they were able to find what was the which were the clusters. And it is not just to say that all of them have Staphylococcus aureus, all of them have an MRSA infection. It is the ability to say who transmitted that, that infection to whom, what is the transmission chain. And because not everyone will be able to understand what this means on the left side, on the right side, if you see, this is P1. And over the next 350 days, the transmission of MRSA was tracked from the first patient to the healthcare worker, who was dealing with this, these infections. And there was a complete understanding of how, despite having one of the most advanced healthcare system, a very well-known infectious agent such as MRSA was able to persist in a hospital, in a community for more than a year. And the complete truth was we were able to find out that it was not just about what was the infection. They were able to find out that maybe it is just simple hand hygiene of one staff member which enabled the persistence of such a difficult to treat infection in even extremely regulated environment such as the UK. That is the power of genomics that we have been using over the past 10, 15 years. And using this, people have now created such amazing global intelligence of the extent of drug resistance, of antimicrobial resistance in the world. We now know that the antimicrobial resistance that we're talking about is not limited to a pocket, is not limited to a geographical pocket, is not limited to a certain kind of drug. Every antibiotic, there is resistance to that almost everywhere in the world. It is just the extent of that antibiotic resistance that has been detected using current methods that is varying. It is very well understood all over the world. The global truth is antibiotic resistance, antimicrobial resistance is here and is a huge danger. The bigger problem is when we start looking closer home. Even when I look at this paper that we worked on, these were preschool children in a rural setting in the west, in the east of India. These children who had no documented evidence of antibiotic therapy, the gut microbiomes of these children showed resistance to beta-lactam, showed resistance to macrolide, metronidazole, and tetracycline. That's the extent of antimicrobial resistance that the world is dealing with. All of this just by doing genomics. And this is the power of genomics that the world is now coming to face with and starting to use as one of the frontline tools, as one of our most important weapons in the fight against infections and in the fight against antimicrobial resistance. And no other disease, it is more clear than tuberculosis again, where whole genome sequencing to diagnose TB has really become one of the greatest tools that the world has seen. Medical microbiology is changing and TB is leading the way. In the UK, in the NHS, it was not only found that whole genome sequencing is not only a more comprehensive and accurate way of finding antimicrobial resistance or finding drug resistance in a TB patient, they also reported that this was more affordable than current day microbiology. The current state of microbiology is state of the art. These are sequencers which are used all over the world, which are not only able to power research, which are not only able to power vaccine discovery, which are not only able to power vaccine delivery and diagnostic target delivery. These are able to help one patient at a time. For each patient for whom the genome has been sequenced of the pathogen, we have a better understanding of antimicrobial resistance, and we are able to provide a better therapy much earlier than current day microbiology. With this, what we now understand is we are able to not only understand what is the antimicrobial resistance. The world is moving towards genome sequencing, which is kit-free. When we do genome sequencing, the future is no longer a test which is looking for Staphylococcus aureus. The future is no longer a test which is looking for tuberculosis, a test which is looking for rifampicin resistance, a test which is looking for carbapenemase resistance. The future is kit-free, where we are able to do genome sequencing and using modern-day computing, able to find out what the infection is about and which antibiotic is going to work. One of the finest minds in the world today in the field of biology extended the thought that nothing in biology makes sense except in the light of evolution. Professor James Shapiro said that nothing in evolution makes sense except in the light of genomics. Genomics is not the future. It is here. It is powering epidemiology. It is powering pandemic resilience, and it is powering the better outcome of a single patient in a single hospital in even a low resource setting. The world is going to take this forward. The big question on our table is, are our clinicians ready? Are our technicians ready to take such results? Are we ready to take an antibiotic resistance report, which provides report for 18 antibiotics, when the previous report was providing resistance profile of only 5 antibiotics? Are the clinicians ready to handle such reports? Are the clinicians ready to order these tests? Can we move into a world guessing what the infection is and then asking for a test? Can we move into a world where we know there is an infection and genome sequencing will point out that is the pathogen and that is the antimicrobial resistance? I think that is the future. Thank you.
Thank you so much, Dr. Anirban. That was very insightful. I open the forum for discussions. I understand that all of you are on mute. So please put any of your queries on the chat box and we'll try to take up as many as possible. So I think we have a query from Dr. Lalit Sawant. In India, we use ICMR, AMR policy or any other standard. I think we are shared policies by not only ICMR but also by NCDC, and we have guidelines. Even at a state level, we do have good guidelines. So yes, we use those. What is more important is, I think, the hospital antibiograms, that when in alignment with the national policies, that comprehensive antibiogram is what makes sense at a hospital level, because it takes into account the hospital, the city, the state, and the national policy. As per the should. So I think again, should as bioinformatician.
I think it is not important to learn deep learning and AI. These are very fancy terms, and these are only applications. Learning better computer science and data science is more important. That would be my take on it. I do tend to have a biased take on such issues. Doing better coding is more important than being able to learn AI.
There is nothing. Is there any guidance for metagenomics use?
RF, I think there are guidelines for metagenomic use in specific cases. There are no broad guidelines. So, for example, what I think what you're referring to is clinical metagenomics. There are several white papers which have come out on clinical metagenomics. I would encourage you to look into FHIR and some of the NCBI resources for that. Having said that, metagenomics is complicated in a way that because we are trying to recreate a microbiome from the data, context becomes very important, and the most important question becomes resolution. What is the resolution that you need? Do you need phylum level resolution, or genus level resolution, or strain level resolution? And based on that, the sequencing will need to be done. And there are several papers on that, and probably a few guidelines as well. The Broad Institute brings out a lot of good practices. I think that's where you should start, good practices in genomics and metagenomics.
I think we have a query from Dr. Anupam Singh. So I think the first query is genome sequencing of MDR bugs in our hospital with infection test?
I think that's just a comment. I don't see a question.
We have one from Dr. Anupam Singh. Is genome sequencing of MDR bugs in our hospital with infection test? I'm sorry, I would need some more clarity on this question. The second part, TB PCR, DNA sent for CBNAT can be sequenced? No. Sensitivity, specificity of AMR genes versus phenotype, limited studies available for phenotypic and genotypic correlation. Centers which have done it themselves vouch by the genotypic results. Status of availability of sequence for rarer bacteria would buttress validation. So infection test is a pan-bacterial platform. So yes, it identifies any rare bacteria that may be present. Concordance of infection test with conventional microbiology. So the concordance has been very good, I must say. The only times I think it has not been concordant is when traditional microbiology could not pick up what sequencing could. We'll move on to the next question.
I think as far as program like NTEP and genomic surveillance and so on, these are already part of several ICMR work. We do hope that we will be able to work with them as well. So ICMR already has an AMR task force which is working on this as well.
Thank you so much, all of you. Thanks for the questions. Thanks for the interest you showed. And again, once more, we apologize for the initial glitch and thank you for the patience that you showed. See you in the forthcoming weeks with more interesting topics and as continuity of this webinar series. Thank you so much. Have a pleasant and a great weekend.